Hello, everyone. Welcome to poster session track 6, Enhancing Mental Health Among Marginalized Groups, session B. We have 6 presenters in today's 50-minute session. So presenters, we will structure this as your 2-minute presentation, followed by around a 3-minute Q&A. So that means about 5 minutes per presenter. I'll put a chat with timing to this effect in there in just a moment. And we'll also have some time at the end for questions of all our presenters. So with that, I'll pass it off to Emily from University of Texas at Tyler. Here is that timing. I apologize that it is in Central Time, but hopefully you will all know what I mean. There you go. So Emily, off to you, and I'll provide some timing as well.
All right, thank you so much. I'll go ahead and start sharing my screen. I learned like this cool trick where you can just like only do the portion of the screen. Let's see if I can get it. Are you all able to see it? Awesome, thank you. So this poster is about attitudes among diverse populations with mental health issues. You know, I kind of wanted to do this. This study is part of like a larger study, but I kind of wanted to look into what people from like diverse racial and ethnic backgrounds like think about all this techie stuff coming out, especially with mental health and like there being stigma within that population. So the methods was that there were 79 participants and they were recruited through an online platform. They self-identified as being from a diverse background and as well as self-identified their mental health condition. And it included like depression, anxiety, were amongst the top mental health conditions. And then they were, of course, asked about their attitudes towards the use of mobile mental health applications. And the results were they expressed a willingness to use mobile apps for accessing information on mental health conditions, tracking symptoms, and receiving reminders for activities and appointments. I think it's really important to understand like why people from like this background are willing to use these sort of apps. I think it could give us insight into how to like kind of like the earlier session was talking about how to improve the applications and kind of gear them towards certain populations if we're wanting to do that. Another interesting find that was also kind of mentioned in the earlier tracks or the earlier session talk or whatever that was that they are more likely to use an app if they were recommended by a qualified provider. Kind of dipping into that stigma thing a little bit. I'm thinking maybe that could be because, you know, mental health is more, I don't know what's the word for it, maybe not appealing, but for lack of a better term, if it's connected with overall health, which tends to have a lot less stigma. So despite historical negative views on mental health, this study shows a positive shift among marginalized groups towards using mobile mental health apps. The literature from my memory is a little bit mixed with how, you know, they're approaching online mental health applications. And again, they're like that increased likelihood of using a mobile application when recommended by that qualified health provider. And that kind of emphasized the importance of collaboration between developers and healthcare professionals for trust and effectiveness. Again, kind of like how we left off on the morning sessions discussion. And then to the right, you kind of see our makeup of this population. It might be a little, see if I can zoom in here. Oops. Well, that's not working. You can see that this is our race ethnicity breakup with a majority of the population citing that they are more than one race, from more than one race or ethnic background. And below are the top 5 agreeableness towards, like, this is what they were wanting to use these mobile applications for. And I kind of discussed them there, but it's learn information about mental health condition, tracking their mental health symptoms, using it for reminders. Again, saying that they would rather use it if they were recommended by a health provider, to receive therapies, as well as help better manage their mental health symptoms. And I think that's all I have. Kind of ran through that a little quickly, sorry.
Awesome. Thank you, Emily. Does anyone have one question for Emily? If so, feel free to unmute. I've never used Prolific before. Had you used that platform, and how did that experience go?
It was I'd never used it before either, and it was pretty straightforward. I liked it a little bit more than mTurk, which is like Amazon's version of it. I think I got like a lot more. It's always been difficult to get a more diverse population, I mean, in research in general. So I think we got like a pretty good number. I think the overall total of this was like almost like 200 people, and within that I was able to get 79. So I enjoyed it.
Awesome. Thank you so much, Emily.
Thank you.
All right, next up is Ilana from Fordham University. Feel free to start sharing whenever.
Yeah, hi everybody. Can you all see this? Okay, great. So hi, my name's Ilana. I'm a counseling psychology PhD student at Fordham, officially in my 4th year, yay, chugging through. So we did a mixed methods virtual study of trauma-sensitive yoga, which is an intervention that got started in Brookline at the JRI and is making its way across the world. So we studied whether TCTSY would be a feasible thing to implement in a safety net hospital. So hospitals where people might not otherwise have access to healthcare generally. So I'll just scroll in a little bit, just being mindful of our time. So we recruited 27 women was the number that actually were able to complete all of the baseline assessments. So that included quantitative and qualitative interviews. We enrolled them in a 10-week, 60-minute-a-week yoga intervention, which they did over Zoom, a HIPAA compliant Zoom platform. And then we did interviews and assessments at 4 time points over the course of the study. So basically what we found from our interviews and from our data was that the intervention was acceptable for those that completed it. So the women that were able to do it loved it. It was life-changing in their words. There was a drop in their symptoms, PTSD, which is who this intervention is for. And it was honestly just like a really, really meaningful experience. That being said, it was hard to retain people in the group. A lot of this was due to not being super invested in the intervention, maybe not understanding it super well, scheduling issues. We held the intervention it was either 10 a.m. or 4 p.m. on a Tuesday and then on a Friday, which made it really hard for folks to participate. A barrier that we had during the intervention itself was that people didn't really understand how to use Zoom specifically for a group. So they said things like, I really wanted to see everybody, but I couldn't because I could only see the person who was talking, right? Or they said it was great, but I don't have a laptop. So I was trying to do it on my phone and I couldn't see anybody. So it was really hard for me to engage. So I think the big takeaways from our study was that it's really meaningful and it's really powerful, especially for those that aren't quite ready to talk about their trauma yet and just want to be able to be in their body. But what we need to do as providers is think about how we can reach folks that might not otherwise, have the actual technology. So maybe providing some technology ed before we start, how to use Zoom in the way that's best for this treatment, providing laptops if they're available, providing iPads so people can have a bigger screen, and then considering maybe like cultural barriers to why yoga might be hard to have buy-in for, why people might not have enrolled to start with. So that's just a really brief overview of our study. There are some pretty powerful quotes, so I'll leave this up during the Q&A, but feel free to let me know if you have any questions.
Awesome. Thanks, Ilana. Any questions from anyone?
Yeah, hi. I was wondering if they would, because PTSD can vary, the PTSD symptoms can vary. So did you like bracket, or did you like categorize women experiencing symptoms on the basis of severity into groups and then go ahead with this? Or because someone with, higher PTSD symptoms might respond differently than someone with lower PTSD symptoms comparatively.
No, we actually didn't, and that's such a great point. So we enrolled women who took the PCL and they scored a 31 or higher, and anyone 31 or up could participate. I think the problem that you're getting at is that yoga really invites you to be in your body and being able to experience your sensations in your body. And for some people, it became too much. So we had a couple folks drop out of the study just because it was too hard to be in their body, and we got them other care. So I think that's a really great avenue to consider, is kind of making different groups with different levels of support based on their symptoms.
Thank you.
Awesome. Thank you so much, Ilana. Next up, we have Shannon from Northwestern University.
Hi, let me know if you guys can see this. Okay, cool. So hi everyone, my name is Shannon, and I'll be presenting on the work my team and I did at Northwestern University on analyzing perinatal participants' perspectives on the acceptability and usability of a technology-enabled service implemented in collaborative care. So in this instance, collaborative care uses the care manager to help integrate mental health care into already established OBGYN practices. So in our study specifically, we recruited participants from this established collaborative care system and then enrolled them into a randomized controlled trial. So today we're going to focus on the treatment arm, and the treatment arm of the trial gave participants access to a smartphone app with activities designed to help with their perinatal mental health. These participants also received support via text just from their care manager to support their use of the app. At mid-treatment of the study, all treatment participants completed surveys to assess their engagement with the app, their bond with their care manager, and also the acceptability of coaching. And then a subset of these participants also completed optional semi-structured interviews about their experiences, and then these interviews were then analyzed using thematic analysis. So from our assessments, we found that participants found the app moderately acceptable, and then the interviews then contextualize this data in the form of themes, which I have up there. And these themes then suggested that overall, when it came to the app, our digital interventions need to be designed to be really user-friendly, self-paced, and also have diverse resources for our perinatal community. And then on the coaching side of treatment, our participants largely connected with our care manager, which is great. However, they also only found coaching semi-acceptable. And then our interviews then also contextualize this. And we found that overall, coaches need to make their messages personalized to each participant and also be supportive of each individual's goals. They can't just copy and paste messages. It really needs to be tailored to the individual. So going forward, I guess what you can take away from this is when you're creating a digital intervention with human support, especially for the perinatal community, we really need to keep in mind the needs of the specific population and really tailor things to their needs. And that's everything. Any questions?
Shannon, curious to hear more about how it went recruiting participants for the study.
Yeah, that's such a good question. So we actually faced a lot of challenges recruiting just because it was an implementation study. And originally we were having our care managers directly recruit, meaning during their original intake interviews with participants in the collaborative care system, we were also having them pitch this study, and that just became way too much on the care manager's plate. So we actually moved recruitment to the study team, but we still worked with the care managers directly. So how that then worked was that the study team would identify potential participants, send that list to care managers, and see if, based upon what the care manager thinks of the participant, as in like where they're at in like their own collaborative care treatment, if this study would then be a good fit for them. And then we would reach out to the participant directly just to see if they would be interested.
Anybody else have a question for Shannon? All right, sounds good. Thank you so much, Shannon. Next up, we have from Mass Gen Hospital.
Hi, everyone. Just a moment, please. Let me go ahead and share my screen. And everyone see the screen? Right. So, hi, everyone. My name is Blessing. I am a clinical research coordinator at Mass General Hospital. Today, I'll be discussing the preliminary findings on the design of a mobile mental health stigma reduction intervention among Black adults. I do not have any relevant disclosures for this poster. So the rationale for the study is among Black adults, depressive and anxiety disorders are often more chronic and severe when compared to white adults. And these disorders are highly stigmatized as well, which often leads to worsened health outcomes. So the objective of the study was really to examine the feasibility of a user-designed video-based mobile mental anti-stigma intervention, which is, according to the literature, pretty comparable in efficacy to face-to-face contact interventions with individuals with a lived experience. So we did conduct 15 elicitation interviews on the design and video content of the app in 1 or 2 sessions, which was then used to develop the prototype for lab testing, and currently also using that information for field testing. For the lab and field testing, we're going through an iterative design process to refine the app based on the feedback that we've received from end users. The results of the current data that we have showed that some key emerging themes were the app was considered acceptable as long as there was video concordance between the user and the person stating the narrative in the videos, as long as there was a shared sort of identity, whether it was gender, ethnicity, or religious, that helped to foster connection between the end user and between the end user when using the app. The length of the video was also important when putting the app together. A lot of users stated that they didn't want the videos too short because they felt like they wouldn't have learned too much in that process, but they didn't want it too long either because then it wouldn't have been engaging. It wouldn't have been friendly to engage with the app. Affordability was also a big one that participants mentioned. They wanted to make sure that this was easy to access, that this wasn't just like another stumbling block in their mental health process if they wanted to learn more about mental health. So those were some of the results that we gathered. And lastly, in terms of the conclusion, we did determine that this app was feasible in addressing culture-specific stigma and health disparities in mental health utilization. Diverse voices can be leveraged using a digital platform to enhance, disseminate, and address health disparities in mental service uptake and utilization. We hope that the future research does consider the role of concordance when looking at video-based interventions.
Thank you so much, Blessing. Any questions from anyone?
I have a question. How did you go about like tailoring these videos to be like for specific like culture specific stigma?
Yes, so the videos narratives were obtained from mental health databases with individuals who are specifically Black and have like different intersecting identities. We wanted to make sure that it was as diverse as possible. So we just sort of gathered through the internet to ensure those videos were available, and those were the videos that we placed in the app.
All right, thank you. Really cool poster.
Thank you.
I'm also curious to know, did having more or sharing more identities with a speaker foster more connection, or was just sharing like one sociodemographic characteristic enough?
That's a really good question. Just one socioeconomic demographic variable shared with the video narrators was enough to sort of engage the participant with the app. So right now we're still in the preliminary stage of the study. As we gather more information on like the different intersecting identities of the participants and the videos that they're watching, I think we'll be able to see more clearly whether, one a sort of a variable would engage the participants more, or if those multiple variables would engage the participants more.
Awesome. Thank you so much, Blessing.
Thank you.
Next up, I'll invite Sophia from University of Alabama at Birmingham to take the stage.
All right, is that working? I think it is. Yeah, all right, cool. So hi everyone, I'm Sophia. I am a doctoral trainee at the Medical Clinical Psychology program at the University of Alabama at Birmingham. And I'm gonna be presenting on some preliminary part of my dissertation work on social media use and coping strategies among Hispanic and Latinx dementia caregivers. And so in general, caregivers of family members living with dementia experience increased anxiety symptoms, increased depression symptoms in relation to their caregiving related stress. In Hispanic Latinx community are at increased risk for experiencing these symptoms as well. And so part of what is impacted, right, in acquiring this responsibility as caregiver is also their social network, right? So their social network becomes restricted, which can lead to increased loneliness, maybe needing more social support. And so social media can be a place where they they can use to decrease these feelings of loneliness, increase social support, and also cope with ongoing stressors. And so what this study is basically looking at is how social media use is related to coping strategies that caregivers may be engaging in. So these are analyses part of an ongoing national level study called Nuestros Días. So this sample includes 52 of our caregivers, and basically we ask caregivers to complete some questionnaires through an online data collection platform. So as you can see, some of the most commonly used platforms, of course, include Facebook, Instagram, and YouTube. In terms of measuring their coping strategies, we use the brief cope inventory, and we also distinguished social media use in between passive, active, and also measured constructs like automaticity and self-regulation. And so what we saw is that avoidance-based and emotion-based coping strategies are the main strategies used among caregivers that are related with their social media use patterns, with avoidance-based strategies specifically being more closely linked with passive social media use. So part of what we are going to be continuing to do here is looking at how these relationships between social media use and the coping strategies that caregivers are employing relates to their daily stress and their long-term mental health outcomes.
Thank you so much, Sophia. Any questions from anyone? For your third measure, is that an objective measure that they're reporting based on what they see in an app, or is that still self-report?
The average use, are you referring to? Yeah,
Yeah,
that's all self-reported. I think as we are going through the study, we are thinking of asking participants to report, or not to report, sorry, to submit like a screenshot maybe of their screen time on the days that they participated in the study, to get maybe a comparison, right, between what is self-reported versus what is the phone saying, right? And see if self-report is accurate as well when it comes to this measure. So that is part of ongoing work too. Good question.
Awesome. Any questions from anyone else? All right, thank you so much, Sophia. Lastly, we have Vishaka from Texas A&M.
Is this visible to everyone? Can you all see my screen?
Yes, we can.
Sorry, I couldn't see you. Thank you so much for that. Hello, everyone. My name is Vishaka. I am a first-year clinical psychology student at Texas A&M, and I'll get started. So I'm going to be presenting a poster which basically is titled Subjective Technology Anxiety in Black Men with Chronic Health Conditions. So in our interconnected, zoomed-in world, there are numerous examples of how technology has successfully empowered patient self-care. But are we losing focus by failing to prepare the very people that these tools are meant to serve? Technology anxiety encapsulates the unease many feel while navigating the evolving landscape of modern tech. So this unease can be understood both as the subjective lack of confidence and the objective lack of know-how, or maybe even a mix of both. So this mini sub-project focused on assessing subjective technology anxiety in 44 Black men aged between 30 to 68 years with different chronic health conditions which are prevalent in this population. And subjective technology anxiety was operationalized as the lack of psychological comfort, which is using the internet and mHealth services for health-related matters. So said another way, the more psychological comfort you experience, the less subjective tech anxiety you will experience. The participants were assessed based on demographics, their plan and intentions to use these services three months down the line, and perceived benefits they thought of using these services. So what the results showed was that using comfort is not associated with age, with income, or education. And it looks like that Black men with type 2 diabetes were the most comfortable in using technology for health. Although it's not significant, interestingly, comfort was also inversely associated with perceived benefits. Overall, if you look at the study, the limitations would be that there is a very small sample size. The participants were not assessed for what was their prior knowledge of using technology and how much help they required or for using that technology. But to conclude, everyone has a different level of comfort while availing technology. And this also relates to people with healthcare problems. So because of those differing levels of comfort, it will also affect how and how much people use these technologies. So we need to keep in mind that when we are developing these technologies, we're also developing a guide to developing and creating a guide for the levels of technological comfort on a continuum, so that we are stepping up our game and meeting people where they are. Thank you.
Thank you so much. Any questions from anyone?
Yeah, I have a question. I'm just curious, when you're thinking about the guide, what types of skills or interventions will be included to support individuals who may feel anxiety around technology?
In terms of just anxiety,
Yeah, or like what will be included in the guide to just support if you don't know how to use something, things like that.
I think first step would be to assess how much people know, because like we're going in with the assumption that everyone knows how to use technology. So it's very important that like whatever we are developing, we either have different levels of the same technology, so that, you know, one is a beginner, one is an advanced, one is an intermediate, or we first assess where they are at, then, you know, build a guide saying that, hey, this is what's needed. We need to develop, say, we need to teach you how to use this, or we need to like work around how can we overcome your fear of technology or your anxiety relating to it. Do we need to develop digital habits? If we're supposed to go, you know, through this, I think we need to keep in mind these personal factors of the population we're trying to also serve.
Awesome, thank you.
Thank you.
Awesome. Thanks, Vishaka.
Thank you.
All right, we have a few minutes left if anyone has any additional questions for any of the presenters. Ilana, I was wondering, for the findings that you had, will you try to apply those learnings and implement the intervention again, or is it kind of wrapped up at this point?
The intervention is done. So we finished up our last time point of data collection in December of 2023, but this was a pilot study, hopefully like for my dissertation. So I think a big takeaway that I have, I think in line with what some folks have been saying, is I think we are using these interventions under the assumption that everybody, I think, A, has access to the technology that we need, and B, knows how to use them. So I think there's a lot of questions about where to go from here. And also just thinking about cultural factors as well is really important. Yeah. Thank you.
Thank you.